All right, welcome everyone to all the postgrads in GYN joining us today. You already know that sacrocolpopexy is just an incredibly effective procedure for treating vaginal vault prolapse. But you also know that navigating the presacral space is kind of like walking through a highly vascular, neurologically dense minefield. So today, this explainer is focused purely on mapping out the precise anatomical coordinates of the space to help you prevent iatrogenic injuries during your mesh fixation. So let's just jump right in and address a major elephant in the room, shall we? Why are S1 nerve injuries chronically underdiagnosed in this procedure? You know how it goes. We often think we're totally clear of the nerves if we don't see an immediate issue while we're in the OR. But the reality? Postoperative pelvic neuropathy often shows up months or honestly even years later. Surgeons might be unknowingly entrapping that S1 nerve just because of some blind suturing a little too far lateral to the sacral promontory. And when secondary nerve entrapment happens, the patient really suffers, and tracing it back to that one specific needle pass is incredibly difficult. To arm you with those exact coordinates, here is our roadmap for this explainer. 1. The hidden surgical risks. 2. Mapping the presacral space. 3. Locating the S1 nerve. 4. Ligament thickness and suturing. And 5. Clinical pearls for sacrocolpopexy. Let's get to it. Starting off with Section 1, the hidden surgical risks. We all know the sacral promontory is the gold standard site for graft fixation, right? But straying even slightly off course here carries huge stakes. Just look at this cadaveric exposure of the presacral space. You can clearly see the suture placement sites relative to the promontory. When you're operating, there's this very natural instinct to displace your fixation sites laterally, usually to avoid the middle sacral artery or that really treacherous sacral venous plexus. But here's the catch. Shifting those sutures to the right pushes your needle dangerously close to unseen neural structures lying just beneath the fascia. Because here's the thing. The S1 nerve is, for all intents and purposes, an invisible landmine during a standard dissection. Because it's completely hidden from your direct line of sight, you absolutely cannot rely on visual confirmation to avoid it. The literature actually shows that nerve damage often results from secondary entrapment by sutures or scar tissue. The only reliable, reproducible way to prevent this, you have to strictly adhere to anatomical coordinates. You've got to operate by the numbers. Moving right along to Section 2, mapping the presacral space. Okay, so how did researchers actually derive these critical coordinates? They used a really rigorous anatomical study of 18 female cadavers to establish an absolute true north for us. To navigate effectively, we obviously need a universal reference point. So the researchers used the midpoint of the sacral promontory, or the MSP, marked right here, to map the surrounding danger zones. Check out the vertical line labeled A and the horizontal line labeled B. By anchoring all these measurements to the MSP, which is super easy to identify in surgery, we get this incredibly reliable geometric map of exactly where not to place our needle. Let's look at how this actually builds our safety margins. The proximity of major vasculature is surprisingly consistent. The left common iliac vein above, the internal iliac artery to the right, and the common iliac vein to the right. They're found at median distances of roughly 22, 22.1, and 21 millimeters away from the MSP. So to put that in perspective, your major vascular structures are sitting, on average, just about 2 centimeters away from your primary reference point. That establishes our very first definitive boundary in the presacral space. Which brings us to Section 3, locating the S1 nerve. Now that we've got our vascular boundaries down, we need to drill into the absolute most critical neural landmark for this procedure. On this slide, physical measurements are directly overlaid onto the cadaveric presacral space. It's such a great visual. You can clearly see the L5-S1 disc. And as we move down and lateral from the sacral promontory, boom, there's the S1 nerve root. By mapping these exact distances, we are entirely removing the guesswork from the equation. Okay, I really want to drill this number into your surgical planning. 2.6 centimeters. Based on the cadaveric measurements, that S1 nerve is found at a median vertical distance of exactly 2.6 centimeters directly below the midpoint of the sacral promontory. And you need to sear this second measurement into your minds too. 1.9 centimeters. Moving from the midline of the sacrum, the S1 nerve is situated 1.9 centimeters lateral to the right. So essentially, your danger zone for the S1 nerve is roughly 2.5 centimeters down and 2 centimeters over. So why does visualization fail us here? The study notes that in all 18 specimens, the first sacral nerve was located just behind the layer of parietal fascia covering the piriformis muscle, meaning it is technically outside the presacral space that we actually dissect. During a routine sacrocolpopexy, that fascia obstructs your view entirely. You literally will not see the nerve. You just have to trust your 2.6 by 1.9 centimeter measurements, not your eyes, to make sure you avoid entrapping it. All right, moving to section 4. Ligament thickness and suturing. So we've mapped the lateral and inferior limits to protect the nerve. Now we've got to shift our focus to depth because we really want to prevent devastating complications like discitis and osteomyelitis. Here, you can see the anterior longitudinal ligament, or ALL, has been cut and reflected right at the level of the mid-sacral promontory. Now, this is the exact physical layer expected to hold your intervening suspension graft. It looks pretty robust, right? And we know it has well-arranged collagen fibers, giving it great tensile strength. But when we look at the actual depth of this tissue, the reality is kind of alarming. Get this, the median thickness of the anterior longitudinal ligament at the sacral promontory is a mere 1.9 millimeters. You have literally less than 2 millimeters of tissue standing between your needle and the underlying bone and disc space. Just let this comparison sink in for a second. The ligament you are suturing into is roughly 1.9 millimeters thick. But studies using intraoperative ultrasound have shown that the average depth of a sacrocolpopexy needle pass is 3.96 millimeters. That means the standard surgeon's bite is literally twice as deep as the ligament itself. This discrepancy is a massive deal, especially in the era of robotic surgery. When you don't have that haptic feedback in a robotic-assisted sacrocolpopexy, your likelihood of inadvertently throwing a suture way deeper than that 2 millimeter safety threshold just skyrockets. Plunging blindly into the L5-S1 disc space doesn't just fail to secure the graft properly, it massively elevates your risk of postoperative discitis and osteomyelitis, and those complications are notoriously brutal to treat and just devastating for the patient. Finally, let's wrap up with Section 5, Clinical Pearls for Sacrocolpopexy. Okay, so we've covered the hidden vasculature, the unseen nerves, and that surprisingly paper-thin ligament. Let's synthesize all of this into some actionable rules of thumb for the OR. First, internally map the S1 nerve on every single patient. It's roughly 2.5 centimeters below the MSB and 2 centimeters to the right. Second, keep your needle placement medial. The absolute shortest distance recorded from the midline to the S1 foramina was just 1.3 centimeters. Any lateral excursion past a centimeter is just playing with fire. Third, rigidly control your needle depth. Remember that ALL is only about 2 millimeters thick. And finally, respect the L5-S1 disc by keeping your fixation strictly to the anterior surface of S1 to entirely avoid the disc space. As the authors of this study perfectly concluded, respecting the ultrastructural constraints of this incredibly thin ligament is just as critical for patient safety as knowing where the nerves are hiding. It really is a game of millimeters in all 3 dimensions: depth, lateral distance, and vertical drop. So I'm going to leave you with this final thought. You now possess the exact coordinates of the presacral space. Knowing exactly where these invisible landmines lie, how are you going to consciously adjust your needle depth and lateral margins the very next time you sit at the console or step up to the table? I challenge you to actively integrate these specific anatomical boundaries into your muscle memory. It'll absolutely make you a safer, more precise surgeon. Thanks so much for joining me on this explainer, and I'll catch you on the next deep dive.